Okay, I'm recording. All right. So this is our exam 2 review. Okay, everybody needs to be on camera. Everybody's names to be in there, so you all get credit for it. So let's start with week 4. We have weeks 4, 5, and 6. Right? Weeks 4 has to do with special vulnerable populations. Okay, so let's talk about vulnerable populations. What are some key points about vulnerable populations that we need to know? I have my notes in front of me, so if I'm looking down, I'm reading from my notes. Okay, so what do we know about vulnerable populations?
They are more vulnerability to the chronic illness.
Okay.
This applied for the populations as homeless, pregnant teens, all LGBT.
They have a higher mortality rate and violence.
What about communicable and infectious diseases? Higher rates for those?
Yes.
Okay. What else?
They are more for pregnancy teenagers, for STDs, HIV, drugs, and they need to be how is vulnerable population, and they need to be screened at least every 6 months. Most the partners who are
hold that thought, Celine. We're going to get to specific. We're going to talk specifically about pregnant teens in a minute. I just want to talk about overall vulnerable populations in general.
Okay.
Okay. Higher mortality rates you talked about. Why might they have higher mortality rates? What might be some factors with that?
Poor living conditions, their diet, health status, and crime and violence.
Yep. Great. All right, let's talk about pregnant adolescents. Okay. What specific additional challenges are pregnant teens going to face?
Finishing school.
Okay. Or not being in school, Christina. So let's talk about what Christina just said. When we're working with pregnant teens, what is one of the most important interventions we can help them with? Christina just answered it. Staying in school. There's a lot of interventions that we can help them with. That is one of the most important. Why? Why do we want to keep them in school during pregnancy? Get them back into school after they've delivered? Why?
Because more education, they can be more empowered to get better conditions of life.
Exactly. What are some challenges that pregnant teens have?
Adaptation to the new baby.
Okay, let's talk about the pregnancy part. Okay, we know that they have higher rates of STDs. Right?
Higher incidence of drug addiction and alcohol.
Absolutely.
Poor nutritional health.
Poor nutrition. Okay, let's talk about a pregnant homeless teen. What additional barriers do they have?
Positive STD.
What about resources? Less resources, more resources? Less. One of the additional huge challenges with pregnant homeless teens is the environment that they're in. Right? More prevalence of maybe violence, domestic violence. Right? definitely more prevalence to mental illness, alcohol issues, substance abuse issues, lack of resources, lack of support, right?
Can poor birth outcomes be one of them?
Absolutely. Poor birth outcomes. Right? Maybe they don't get to they don't have their first prenatal visit till the second or even third trimester. Right? Because they don't have the resources. Poor birth outcomes. What does that look like? Maybe preemie. Maybe low birth weight. And depending how their pregnancy has been, maybe poor outcomes. Right? I think these were in your week 4 notes about when working with pregnant teens or pregnant homeless teens or both, because they have an increased risk of being involved in intimate partner violence, domestic violence, violence in general. We have to try and help them develop a safety plan. What does that safety plan need to include? What do we need in that safety plan?
Nutrition, housing,
Shelter,
Pardon me?
shelter,
Shelter? What else?
You said pregnant homeless teens,
Pregnant teen, pregnant homeless teen.
making sure they go back to school.
No, I'm talking about a safety plan.
Oh, a safety plan. Okay.
Yes. What has to be in their safety plan?
Where to go in case of violence,
Okay.
shelters.
How about assess how much the mother knows and understands the needs of infant and their development?
We'll get to that after they deliver. I want to talk about a safety plan, a bag, right, with clothing, maybe a credit card that's non-traceable, a list of phone numbers of shelters. Remember, this is a pregnant teen that's in a domestic violence situation or an intimate part violation, relationship. Go back and read through your week. Does anybody have their week 4 notes that they can pull up that talks about a safety plan?
yeah,
Okay, Krista,
safety
what does it
plan.
say? What does it say? There's information in there about a safety plan. What is it?
I know it's saying something about important documents, money, the credit card that you said, a spare car keys, phone numbers of nearby shelters, and visiting the National Domestic Violence Help Hotline website. It's in paragraph. Hold on, Ms. Marvin. I'm gonna let everybody know what paragraph it's in. 1, 2, 3, 4. Paragraph 5, y'all.
Okay,
Right
so
after
safety plan.
Yeah, it's right after
Yep.
the line that say abuse, trauma, neglect, and sexual victimization.
Okay. All right, so let's talk about the postpartum visit. You're the home health nurse, you're out there, you're going to be doing a postpartum visit on a new teen mom. Okay, what are some positive things you want to look for?
The growth and development of their child.
If they are bonding, how much they know about the development of the baby, how to take care of the baby.
Yep. We want to make sure they have an understanding of what normal growth and development is, right? We want to make sure that they have an understanding of how to meet this new baby's needs when the baby's crying, or can they assess what's going on? What are some red flags?
When a mother is not connecting.
Not caring for her and her baby. Not caring for
Mhm.
herself and her baby.
Not being able to meet the needs. Right? Part of your assessment is also going to be to look around in the environment. What's going on? Is it a calm
Living
environment?
condition,
Pardon me?
living conditions.
Yeah. Are there other people involved in the house? What does that look like? Is it a calm, safe, healthy environment, or is it a chaotic, dysfunctional environment? Right? Very important to assess that. We already talked about 14s being nearly 3 times more likely to drop out of school. What programs can we help them with to complete their education? Like Celine said, continuing your education increases for a better future, which improves healthcare for both the mom and the baby. Okay. All right, let's jump to the LGBT population. In caring for this population, what are some of the most important things that what do we need to first consider?
Our feelings towards them or
Yes.
how they feel in general?
Yes, our own feelings. Are we able to competently care for this population
No matter.
with with compassion, openness, non-judgment, being non-judgmental, right? Because we know that this particular population may be judged throughout their entire lifetime, right? Not just as kids or adolescents or high school. This may be a lifelong challenge as they seek out their resources and their care. So I think it was Kimberly who said one of the first things that needs to happen is we need to check our own emotions and our own beliefs and our own values and our own practices to make sure there are no biases or prejudices, right? Otherwise, how are we going to competently care?
That's why
This
I feel like
population.
it's just safe that people mind their own business. Love is love. That's what I say.
I love having Crystal in my classes. Yeah, that's exactly right. What she just said. So, let's say we're meeting with and talking with members of this population, right? How do we want to speak with them to come across as being non-judgmental? What kinds of questions do we want to ask them?
Are you in a relationship? Do you have a partner?
Mhm.
What do you call your partner?
Mhm.
Are you
Not judge them, not make judge to them.
Right. Non-judgmental questions.
Mhm.
Right? Just like Crystal said, she gave some examples. We don't want to assume heterosexuality, right?
Mhm.
So how do we find the questions to ask that don't assume that?
make
The other thing about this particular concept is understanding the screening process. Okay, for this particular population, there is a suggested annual screenings for this population. What do those screenings include?
STD,
Mm-hmm.
HIV.
Mm-hmm. There's 5.
HIV,
Mm-hmm.
HIV, syphilis, gonorrhea, genital herpes, and chlamydia.
Awesome. Yes. And then what happens to that? It's recommended as an annual screening, but what happens if they're more high risk? And what is
3
more
to
high?
6 months.
What?
3 to 6 months.
Yeah, 3 to 6 months. What do we consider more high risk? There's 2 things we consider more high risk.
Multiple partners.
Uh-huh.
Mhm.
And
The ones that use illicit drugs.
the ones what? What's the other?
The
What's
one
the other?
that uses
illicit drugs.
in
Using
conjunction with
illicit
work.
drugs, yes, yes. Using illicit drugs in conjunction with the sex. Those are considered your more high risk part of this population. And that screening jumps to 3 to 6 months versus annually, right? All right, let's jump to mental illness, anxiety, mood and eating disorders. Okay, what's generalized anxiety disorder? How would you characterize that?
Nervous, worry too much.
A
About
person who
multiple things at one time, right? What else about that? Persistent, unrealistic, excessive worry about 2 or more life circumstances for at least 6 months or longer. Right? That's why it's generalized. Okay. What about phobias? What's important to know about phobias? What's a phobia?
It's a fear
Well,
of
it's
something or
excessive, irrational fear, right? It can be about an activity, a situation, an object, right? This obsessive fear leads to extreme anxiety, right? That's a phobia. What about OCD? What's OCD?
It is a recurrent obsession.
Mm-hmm.
reoccurring.
Obsessive, right? Something that you feel obsessed to perform, washing your hands, turning off lights. I don't know, what else? What are some other examples?
I mean, I know
checking the doorknob.
I know you got to keep your house clean, but like just constantly like cleaning.
Mm-hmm, 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 mm-hmm. What about PTSD? What's PTSD?
Post-traumatic stress.
Which is what? What's PTSD? What has to happen?
It happens after a traumatizing event.
Mm-hmm. This is one of your quiz questions. It's those recurrent, right? The recurrent remembrance of something you can't get out of your mind, right? Produces feelings of intense distress, along with anxiety, nightmares, flashbacks. Remember that in your quiz question? Hey, what about suicidal ideations? What if you're working with somebody that has suicidal ideations? What's one of the most important things to consider?
If they have a plan.
If they have a plan, is it okay to ask them, do you have a plan? Do you have the means to carry out your plan? Have you had previous attempts? Right? Let's say you're working with a client who is suicidal in a hospital. What's the most important thing you need to consider after you ask these questions?
Safety.
Safety. Right? Do they have access to utensils or access to anything in their room that would allow them to carry out things or carry out their plan, right? What's our the one medication I asked you guys to be familiar with was lithium. Okay,
For bipolar disorders.
yeah, lithium is often treated. Well, let's take a step back. Bipolar. Okay, what is bipolar?
Swings mood. They can be down and some other times very high,
Mhm.
irrational,
Mhm.
They-
Mhm. Client may experience episodes of extreme sadness, hopelessness, helplessness. And on the flip side, periods of extreme elation or hyperactivity. It's the ups and downs, right? Typically, bipolar is treated with lithium. What's lithium? What kind of drug is it?
Mood stabilizer.
Mood stabilizer, right? What do we want to know about patient teaching with lithium?
About certain labels. Be careful about the no presents I call it's tremors, vomit,
Mhm.
diarrhea, hypothermia.
Okay. Couple of additional teaching tools. Encourage normal salt intake. Increase your fluids. Remember one of our quiz questions, the answer was keep them NPO? No,
No.
we don't
No.
no. That was the correct answer because it was asking what do you don't want to do, right? So salt intake, encouraging fluids. Take it with meals to try and prevent your GI distress from taking it with meals. Avoid caffeinated drinks, right? Because lithium does have a diuretic effect. Okay. Celine already said, report diarrhea, vomiting, tremors, any kind of lack of coordination. Okay. Substance abuse. What do we know about alcoholism? What does alcoholism do to your body?
It's associated with B vitamin deficiency, like folate, low magnesium, low potassium, iron deficiency, and anemia.
It's also a depressant, right? May cause drowsiness, respiratory depression, lethargy, confusion. Blood alcohol concentration. Is it measured only by the amount you drink? What are some other factors? What are some other what else factors into a blood alcohol concentration level?
If the gender it is more can be more concentrated in women than men. The weight.
Well, let's be more specific here.
So the rate of drinking, the rate of absorption, so like that determines the presence of food, their
Yep.
metabolism.
Yep. So the point is that it's not only focused on how much you drink. Okay, there's several other factors that play into that, right? And in your notes, it talks about what the liver can metabolize. Okay. 0.25 ounces of whiskey, 4 ounces of wine, 12 ounces of beer. That's important to know what the liver can metabolize.
Where do you see that at?
It's in your section about alcoholism. In your substance abuse section, it would be still in your week 4 notes. What about a client who's experiencing withdrawal symptoms from alcohol? What might you see? What might you observe?
Tremors, shaking.
Is take care for they no harm themselves.
Okay. Agitation, anxiety.
Irritability, anxiety, agitation.
Yeah. What kind of environment do we want to provide for them?
Calm.
Calm, low stimulation. Right? Let's say they're having hallucinations, trying to help them work through that in a therapeutic way, right? Tobacco. What's the issue with tobacco? I'm not talking about e-cigarettes now. I'm just talking tobacco. What's the issue? Highly addictive. Produces
read.
what?
I'm sorry.
No, go ahead.
Say cancer, lung cancer,
Mhm.
many other.
Respiratory issues, asthma, COPD.
Heart disease.
Mhm. Mhm. What about kids who are exposed to smoke? What risks do they have?
Asthma.
Respiratory and ear infection.
Ear infections. What about moms who smoke during pregnancy? What are some risks for that?
Low birth weight.
Mhm. Maybe premature.
You
Yeah.
get premature stillborn and
Mhm.
SIDS.
Let's talk about e-cigarettes. What's the biggest risk for e-cigarettes?
The chemical in this cigarettes is more poisonous.
The
Exactly.
toxic. Oh. mm.
Go ahead, Crystal. The oil in these vapes and e-cigarettes is poisonous to kids. Right? Remember talking about that in class?
Mhm.
And the vapor that comes from these and the increase in lung damage. Right? All right, let's talk about cocaine, amphetamines, and methamphetamines. What are they? What kind of drugs are they? Stimulants?
Yes.
Okay, so let's say somebody's come to the urgent care and you're working and you suspect a cocaine overdose. What are you going to see?
High
High
blood,
Go ahead. What are we going to see?
high body temp, high heart rate,
Okay.
blood pressure.
Okay.
Fixed pupils.
Okay.
Like they're not dilating.
Okay.
Um,
Okay. What
probably
about
foaming out the mouth.
okay? What about
excited.
okay? Yep. Yep. What about amphetamines? What are you going to see?
But they're
Frantic and excited speech.
Mhm. Mhm. What else? What is an opioid overdose or opioid intoxication look like?
Would it be the pinpoint pupils?
Mm-hmm. 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 Pinpoint pupils, slurred speech, inattention, lethargy, impaired memory, impaired judgment. Okay, so be able to identify what, cocaine intoxication, amphetamine intoxication, methamphetamine intoxication looks like. There's a lot of similarities, but there's some differences. Okay.
Like cocaine make everything high and the amphetamine slow everything.
Mm-hmm. Yeah. Okay, so that's week 4. That's an overview of week 4. I encourage you, as you're preparing for this exam, go back and review your weekly notes. Go back and review your readings. If you missed any part of lecture during these 3 weeks, just go back and listen to the part of lecture that you missed or re-listen to the lecture. You're obviously here live, so that's great. You will have a recording of this review. You already have Professor Ford's review. I sent that on Wednesday. And then you'll have one more review to attend on Sunday if you want. And if you can't attend that, you can watch the recording. So you have 3 different recordings. It's the same content being provided. It's just maybe the way we provide it. So those are all your resources. Okay, let's jump into week 5. Okay, we're talking about death, dying, hospice, palliative care. What's hospice care? What is it?
Is that to improve quality of life?
Yeah, but
And
yes, but what is hospice?
would it alleviate suffering and provide end of life experience?
What's the purpose? Yes, we're getting there. Primary goal of hospice and palliative care is to improve the quality of life. How do we do that? We just started talking about that. Alleviating suffering. Improve that end of life experience the best we can for the client and their loved ones, right? Making sure there's effective communication between you, the hospice nurse, and the client, and the families. Right? Focusing on the needs of the client, keeping the client comfortable, maintaining dignity and self-esteem. Right? What else? We want the client participating as much as they want in their decision making, right? We encourage that, right? That's called autonomy. We don't want to be making decisions for the clients if they're capable of making them, right?
Correct.
I have a question. I'm very confused with the difference between hospice and palliative care. Because
Palliative
some are
pal-
similar or not.
palliative care is, let's say they're diagnosed with something and they have 6 months to live. Palliative care is that process between the time of diagnosis and the time that they go into hospice, where hospice is the true end of life care, right? Where there's no more treatments. This is truly end of life, right? All the aggressive treatments have been stopped. Palliative care is leading up to that process.
Okay.
Does that make sense?
Yes.
So they'll be receiving palliative care until they're moved into hospice.
Okay. So
Comfort
how
care. Comfort
to
care.
begin for the end of the life for the client?
Mhm.
We need to give the most comfort and respect the autonomy of the client.
I want to focus on hospice care because that's really
Okay.
what this concept is. Hospice care, which is true end of life. All treatments have been stopped.
Okay.
Right, is basically keeping the client or patient comfortable until the end. Okay. Focusing on symptom management, right? And providing comfort care. Right. The client and the family need to have an understanding that there is no cure at this point, right? This is essentially comfort and comfort care. Okay. As you get to the end stages, what are you likely to observe? What are you likely to observe in a client who's close to death?
The signs and symptoms you asked?
Yeah. What are you likely to observe with their breathing?
Cool,
Push mouth.
small, rapid respirations.
Say that again, Brandy.
Cool, small respirations.
Mm-hmm. Mm-hmm. What
Their
else?
eyes start to get glossy.
What else?
Heart rate starts to slow down.
Mm-hmm.
Colors in their body start to change.
Mm-hmm. What are Chine-Stokes respirations?
That's the Is that the
But-
def?
Like with apnea, periods of apnea.
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 Apnea. Shallow breathing with periods of apnea, right? Stages of grief. The client, their family members, everybody's going to be in different stages of grief, right? Oh, I think we need to mute somebody. There's a lot of background noise. Okay, there we go. Coroner investigating deaths. This is in your notes in week 5. What kinds of deaths will a coroner investigate? Anything that's suspicious, right?
Suspected suicides,
Suicide.
the injury,
And what's the last one? Clients that are not under the care of a primary care provider, right? There's no reason that you would investigate all deaths at home or all deaths in the hospital or all deaths in the long-term care facility, right? It's when there's a suspected problem or suspected question with the cause, right? What about spirituality and culture? What is culturally competent care? If you are providing culturally competent care, what have you been able to attain? And what does culturally competent care look like?
like be competent in with everybody, care of spirituality about the clients, understand their own culture, their own spirituality, and
Mhm.
respect that, and help them or support them in the way where we can help spirituality.
We need to be able to look at each client as unique, right? Our culture, my culture is not better than your culture. Cultures are not better than one culture is not better than anybody else's. Everybody has their own culture, right? And that culture represents certain values, certain beliefs, certain practices that may include visitor limitations, food preferences. What else? Communication preferences, right? Being culturally competent means that we are able to look at a client through their own eyes. Okay? Not every culture should be treated the same. Right? Every culture is different. Okay, we don't expect to be treated the same as a different culture. Everybody's treated differently. Okay? Requires we have an understanding of our own culture, our own biases, our own stereotypes. Right? In this world, we are interacting and caring for lots of different clients from lots of different cultures, right? It is a learning process that is ongoing. Okay, I consider myself culturally competent, but I'm always learning. Okay? We can't make any assumptions. Right? We can't place our culture above others. Excuse me. And the other thing we have to try and do is we have to try and incorporate, spoke about this in class this week. Excuse me. We have to try to incorporate as much of the client's cultural values, beliefs, practices into their healthcare plan. And we can usually accommodate most of that, but there are some things we can't accommodate. But we have to try. So being aware of whatever values, beliefs, practices they have, we need to do our best to incorporate that into the plan of care. And in, I think it's in your week 5 notes, I gave some examples in your notes about certain kind of cultures and a few different cultures and a few preferences. Okay. What else about culture? There's one other thing I wanted to mention. Cultural competence, this is in your notes, is attained when the nurse can make a conscious attempt to learn about people of diverse cultures and try and look at the world through their perspective. That's the fancy definition. But that's basically what it is, being able to look at it, look through a client's, look at their perspective. How are they looking at things? Oh, I know what I want to ask you. What if you're taking care of a client that has a culture that you've never taken care of before? What can you do to improve your cultural competence with that client?
Ask.
What?
I will ask about
Ask. Most clients are happy to talk about their cultures and their preferences and their practices and their beliefs. But if you don't know, you need to ask. Maybe you work with somebody who has the same culture. Ask. Ask the client, ask your coworkers. Research. Do your own research. Right? The expectation is that we're able to competently and safely care for all clients of different cultures. I did this in the schools all the time. Lots of different pockets of different cultures and communities. Right? If I wasn't comfortable, I asked the parents. You know, what is it about a clinic visit we need to know? What is it about food preferences we need to know? What is it about communication that we need to know with your kids? Okay. All right. Ethics and legal issues. What's the first step in ethical decision making? What do you have to have?
identify the issues.
An issue. How are you going to go through an ethical decision making process if you don't have an issue? Okay. Couple of ethical principles. What's beneficence?
Do good.
Beneficence, do good. What's an example? What are some examples of beneficence?
Raise up the side rails of the bed.
Yep.
Or fill the water before the client get a shower.
Mm-hmm. Do good. What would all of us do in the same situation? Ethics is doing good. What is morally right? What is morally good? That's what ethics is all about. Right? So beneficence is doing good. Right? What would all of us do in a certain situation? We would try and do what's morally right. What's good. Another example, pain control. Trying to keep the client comfortable. That's doing good. There's another principle of non-malfeasance. What is that?
Do no harm.
Do no harm. So if we were all presented with the same situation, we would all be trying to practicing non-malfeasance, which is do no harm. The example we brought up in class is, let's say you're cathing a patient, right? And you contaminate the field. What do?
Start over everything.
Exactly. Go get a new kit and start over. Do no harm. You don't want to increase the risk of infection or injury. Another principle is autonomy. What's autonomy?
Be have adjustment where we can do or carry out things or assessments to do or have decisions to do. It's
The
our-
patients, autonomy. We want them to be as autonomous as possible. We want them to participate in their plan of care.
Yeah, have the right to stop and continue care.
Pardon me?
Yeah, I said have the right about their own care on when to stop
Right.
and when to.
Right. We don't want to be making decisions for them if they can make decisions on their own. Right? That's autonomy. We want to make decisions like Ayobami just said, making decisions for our own kids. I have the autonomy to do that. Well, we want the clients to have the autonomy, families to have the autonomy. Sounds good, Danya. Thank you for coming. We want the clients and their families to have the autonomy to make their own decisions about what they want. Especially, let's think back to hospice care. We want them to make decisions about how they want their end of life to go. Do they want feeding tubes? Do they want IV fluids? What kind of pain control do they want? We don't want to be making decisions for them if they can do it. The last one, a principle is distributive justice. What's that?
Be equal with everybody.
That the resources available are distributed equally. That's distributive justice. Okay, the example that I always come to is, let's say you're a nurse working with an insurance company, right? And there's this new medication that helps treat hypertension. But that medication isn't covered in this client's insurance. It would be up to us as the nurse to discuss with that insurance company, right? The benefit of providing this kind of medication to a client. Even though it's not covered by insurance, it will help the patient. And it may decrease further admissions. You're advocating for distributive justice. Does that make sense? Yes? Okay. Documentation. What does documentation look like? What does it have to be? We all document.
Factual.
It should be descriptive, objective, and informative.
Yep. Descriptive, objective information, not what we see or what we feel, what we think. Right? So, just I think a couple of examples here. The patient the patient is anxious this morning. Did the patient tell you that, or is that your observation? Well, maybe if the patient said, I had a really rough night, the anti-anxiety medication they gave me before bed didn't work, I'm super anxious. Yeah, the patient has told you that. That is factual documentation. Well, let's say you walk in after shift change and the patient is acting crabby or whatever. You can't make assumptions and chart those. Those are your feelings, right? Those aren't objective, they're subjective. Okay? You can't infer something without supporting it with factual data. Right? So it appears like, no. Right? It just seems like you're stating your opinion. All right. So, does that make sense? Okay. And the other ethical and legal issue we brought up during class was floating. right? We're all gonna, has anybody ever been asked to float to a unit they've never been to before? They don't have a clue. I have. Have you guys? Yeah. So what's the safe way to handle this? You have to be able to identify what you can perform safely. Can you perform vital signs safely on these clients? Can you serve food trays? Can you prepare for discharge? What is it that you can do safely? We talked about this in class. Right? There may be a lot of areas that you can't help this unit out in, but there may be areas that you can. So it's up to you to discuss with whoever the charge nurse is, the manager, whoever. Yes, I'm here to help, but here's what I can safely do, and here's what I am not comfortable doing. That's an ethical, that's kind of a moral distress issue, right? But you can deal with it. It's up to you to communicate. What can you do safely and what can you not?
So we cannot refuse the float.
You can?
We can, but we can say to our North charge or leader that reason why.
Okay, well, that's good. A lot of people working in organizations don't have the ability to refuse floating. If you do, that's fine. But if you don't, that's what I'm talking about, is how do you go to another floor and be able to communicate effectively what you don't feel competent, what tasks you don't feel competent performing, and what tasks you do. Does that help,
Okay.
Celine?
Right, yes.
Okay, and then this past week, occupational environmental health. What's the job of the occupational nurse? Well, first of all, where's occupational nursing taking place?
Environmental workplace.
In the workplace, right? Occupational health is in the workplace. What are some of the functions of the occupational health nurse? What is her overall, what's her job? Keeping the workplace safe, right? Being aware of what risks are in the workplaces, what job descriptions people have. Have they been trained to carry out their job descriptions? Had they been trained about the risks in the environments they work in? I brought up the example today in class. Let's say you're working in an organization that has a transport service. Do the people who work in transport services know how to appropriately lift a patient, transfer a patient, use the side rails? Somebody who's working as a scrub person in the OR, do they know how to use PPE appropriately? Do they know hygiene techniques that have to be implemented in that area? Right? That's the occupational health nurse's job, to know what jobs are in the organization or institution or place of work, what risks they propose or pose, and how to safely deal with that. Right? As we said in class this week, there is no safe occupation or place of work. Everything comes with risks. They just look different in different organizations. Then we have OSHA, Occupational Safety and Health Administration. Okay, they're responsible for making sure all of our organizations are following the guidelines and laws for workplace safety that have been put in place. It's going to look different from a hospital, for a long-term rehab, for a fast food place, for a urgent care. But everybody has safety standards they have to follow based on where they work. OSHA is responsible for enforcing those. They want to make sure that each organization or workplace is following the safety guidelines, thus to prevent illness and injury. If there are on-the-job injuries or out of workplace injuries, but the employee's wanting to come back to work. The occupational nurse works with that too. You know, what's the injury? What was the surgery or what was the treatment? When can they come back to work? If they can, what does the doctor say? Are there any restrictions? Do they have to come back limited duty, full duty? If so, what does that look like? Do they need retraining? Okay, for whatever happened. We talked about this today, working in a big industrial plant, noisy plant. Do the employees have proper hearing protective equipment? Working with all the chemicals, what happens is there's a chemical spill. Do employees know what to do? Or do employees know how to prevent chemical spills or any kind of hazardous spill? So occupational health is all about the workplace. Safe workplace. Employees are at work 100% competent to carry out the duties of their job description. And that occupational nurse works with prevention on the primary level, right? Maybe they're doing in-services on healthy lifestyle, balancing work and family. Okay, because we know we spend lots and lots of time at work. A lot of people bring a lot of stuff to work. Okay, whether they're mental health issues, anxiety, maybe issues of violence going on in their home, substance abuse, alcohol abuse. People bring that stuff to work. All right, so that's another job of the occupational nurses. Who's at risk? How can we help them? How can we provide them resources so that they can safely come to work and function? Right? A lot of issues in the workplace, a lot of workplace violence. Okay.
Please, I have a question.
Sure.
Please, is it the occupational nurse that determines the PPE that is right for a particular work?
Yeah. Ayobami,
Is
can
it-
you look in the camera because I can't really see you and I'm trying to understand your question.
Okay, I'm
Go ahead.
asking that, is it the occupational nurse that determines the PPE, the personal protective equipment that staff wear at work? Is it the job of the occupational nurse to determine that, or is it the OSHA? I'm talking about the PPE you wear at work.
Yeah.
Is it the occupational nurse that determines the type of PPE you wear, or?
Well, it depends on what your job is, right? Depends on where you're working in your organization. If you're in an organization, I mean, we know everybody's wearing gloves, right? But let's say you're working in the OR. Your level of use of PPE is going to be much more extensive than say if you're working on the floor, right? Or if you're working with a patient that has TB, right? Where you have all that equipment set up outside the room. So it would be up to the occupational nurse to ensure that people in different areas of the organization are appropriately using their PPE based on what risks there are and what their job description is. Does that help? Okay. And then the last topic that we did this week was client teaching. What's the most common and biggest issue with teaching? Talked about this week. It's a barrier.
Low literacy.
Low
Barrier.
literacy. Okay. How do we work around low literacy if we're teaching? Okay. How do we ensure that a client can read and comprehend? A lot of times people don't want to disclose that they can't read or they can't understand. They're embarrassed or whatever. So they will do whatever to try and make you believe that they can understand. What do we do? What's one of the best ways to assess reading and comprehension?
Feedback or teach back?
Have them read something. If their primary language is something other than English, have something printed in their primary language and have them read it. And then go through it. If you don't understand it, you're going to have somebody that understands it, help you, an interpreter. Okay, you have to be able to assess the reading level and the comprehension level. A lot of times if you want to depend on family, if there's an interpreter available, that's first. You know, how do we know if we're trying to teach the families as well, how do we know their reading levels and their comprehension levels? Right? Discharge planning requires looking ahead in order to meet the client's ongoing needs. It's something that starts at admission. We know that, right? And then remember the domains of learning. The cognitive is your thinking. What are you hearing? What are you understanding? The affective is the feeling. You know, let's say you're going to an in-service on something you don't believe in. I don't know, or something you're required to go with work, but you don't really believe in it. Whatever it is. Are you less apt or more apt to learn? Probably less. So it's the feeling part of it. What are your attitudes? What are your beliefs? That's going to affect your learning as well. And same with psychomotor. That's the doing. That's the hands-on. We all have all this cognitive, affective, psychomotor, but one is typically dominant. Okay, for me, I'm a psychomotor learner. I like hands-on stuff. I like to practice with things. So I used to do with the kids in the schools with the new diabetics, with the glucometers. They had one, I had one. We practiced hands-on practice experience. Well, one of the things you need to consider when teaching is your room full of clients is going to be all three of these domains. Some are going to be cognitive learners, some are going to be affective learners, some are going to be psychomotor learners. How do you adapt and adjust for that? Some learners are visual learners. They can like a PowerPoint to read through it. Some are auditory. Some are kinesthetic, right? The doing. Okay, so client teaching is, yes, we do it every day, all day, but it can, who's your client? Are you doing teaching with an individual? Are you doing teaching with a family? Are you doing teaching in a population? All those things have to be considered when you're teaching, knowing your audience, knowing your room. I said this morning in my class, what if you have people in your audience who are hearing impaired? Are you going to adjust for that? What if you have visually impaired? Are you going to adjust for that? What if you have issues with motivation with part of your group? How are you going to adjust to that? It's really easy to do teaching one-on-one, right? Once you've assessed what the learning needs are and those kinds of things. But what if you're in groups? You can have all different kinds of learners in your groups. So it becomes challenging to be able to effectively reach everybody, right? So that was it. Those are my, gosh, we went over an hour. That's great. Is this helpful? Did you take good notes? Hey, there's the exam. There's no trick questions or there's no gotcha questions. This is straightforward stuff. Okay, you understand the concepts, you'll be fine. Okay, and a lot of these concepts have already been introduced to you in one way or another in previous classes. We're just taking these concepts and now moving them into care in the community. All right. And I like to bring up my school nurse stuff. You're going to care. I'm going to care for a client, a kid in school differently in a school setting than you're going to care for a pediatric patient with asthma in the hospital, right? Your care in the hospital for the last couple of days may have been to help with a asthma exacerbation, right? Neb treatments, O2 monitoring. Your job is to get them stabilized to get them home, right? Then the kid with asthma comes to school. What's my job? My job is check in with the parent, get the discharge instructions. What are the doctors saying? Making sure they have their inhaler in school, making sure the teacher knows that if they have any signs of it, breathing issues, send them down to the clinic. Do they need to be pre-treated before they go to gym? Okay, it's the same kid with the same diagnosis, just being treated differently in different settings. Does that make sense? Questions? So, most of you guys are my students, which is great. I have some other students from other classes. So what I will encourage you to do is do your due diligence in preparing for the exam. Okay? Crystal's shaking her head. She already knows what I'm going to say, right? Do your due diligence. Okay. After you've done your due diligence and feel like you have adequately prepared for the exam, if concepts are still unclear, I want you to reach out to me or your professor, or me if I'm not your professor, whatever. I want you to have the opportunity to reach out and clarify and go through any concepts you're still struggling with. Okay, Howard, we talked about this yesterday, right? Okay, so you have to use the resources you have in your instructors preparing for an exam. Okay, so I'm going to assume if I don't hear from you, you are ready to go, right? And if you're not ready to go, it's up to you to reach out. Okay, this is straightforward stuff. Okay.
Since you asked, can I come to your Friday class to take my exam? I can't. God dang. I mean, I'm gonna be ready, but I just want to be extra ready.
Unless you have a medical emergency that you can give me a doctor's note for. Well, actually, I take that back. You could, Crystal, come to my Friday class, but you'd have to take a 10% deduction on the exam.
Oh, nope, not gonna do that.
Right. Right. So that's my TED Talk for today.
I don't see you said it's in the notes about the coroner. I don't see that.
The what?
The coroner. What the coroner's gotta look for. Doing
That's
the
not your notes?
And I don't look and I don't read over it like.
Did you take notes on it?
Yeah, but you said look in your notes for the rest, and
No.
I was like, well, it's not in
Maybe
here.
maybe I took that out this term. As long as
Yeah.
you took notes on it. As long as you took notes on it.
Okay.
Okay. All right. Does anybody have any questions? This was a pretty long and detailed review. I hope you learned a lot from it.
Yeah, I did. I'm gonna go back and I'm gonna listen to the recording again.
Yeah, of course. And as soon as I get the recording, I'll send it off and to both my students, and I'll send it off to Professor Kershaw and Professor Ford so they can post it in their announcements. And remember, there's another review coming up Sunday evening. Professor Kershaw will cover the same concepts. She just might deliver it in a different way. So that's another opportunity. And lastly, thank you. Thank you for prioritizing your time this morning to come to this. I hope it was helpful. And again, reach out if you have any follow-up questions or need any follow-up help. Okay. I'm going to stop the recording, but I'll stay on if anybody has any other questions. All right.
Thank you.
And then Ayobami,
Yes.
you came in late. And so my expectation of you is that you watch the part of the recording at the beginning that you missed. Is
Yeah, I
that
will do that.
fair?